My first love was figuring out how we could treat these tumors topically without having to hack up the eye surface. And then I became interested in the new technology, which allows me to see what's going on. And really, for the most part, it really makes me look smart because I can see what is there and give a diagnosis. So I have no financial interests to disclose, but I will be discussing, again, off-label use. So we'll do another case. This is a gentleman who came in with this lesion on the eye surface. And what you'll see is he said he had a pterygium for a long time, which that could be. But he thought it changed. And you see here, this is rose Bengal staining. That there is some rose Bengal staining now on top of this quote unquote pterygium. So the question is this iridium? Is there neoplastic? Is it both? What's going on? And so I like to joke with my fellows that I use my women's intuition to figure out if a tumor is a problem, if a lesion is a problem, or if it's not a problem. So I need to know whether I'm going to be relaxed or worried. And I can use my women's intuition, but what works really well is the high resolution OCT as my intuition meter. So I could biopsy, and in a biopsy for OSSN, what you see is an abrupt transition with thickened epithelium and disorganized epithelium that has dyskeratosis, parakeratosis, and as I said, the abrupt transition. And when it's invasive, it goes through the basement membrane. So we mentioned this in my last lecture. The first device that I used was a custom device. One of my colleagues, Dr. Jay Wang, who is a biomedical engineer, devised this for the ocular surface to look at the tear lake and dry eye features. And that device had 2 to 3 microns of resolution, and that's what I started with. And now I use a commercially available device of the OptiView, and that is the images that you're going to see today. And this has actually a resolution of 5 to 7 microns. Most ophthalmologists have an OCT in their office, but just not the adapter that lets them look at the surface of the eye. So I think that's something that everyone should think about and get used to looking at the ocular surface with their OCT. So what do we see? So the Vizanti, for example, this is a time domain device. It has 18 microns of resolution. It really is not good at looking at any details of the epithelium. It's very good at looking depth and looking at IOLs, positioning, etc. But when you look at the spectral domain device, this was our research device, you can really see details. You see the tear film first, and then you see the epithelium, and then you see the stroma, and you can see details of the endothelium too, which my colleague, Dr. Mohammed Abu-Shusha, has published on. So we've looked at this already, but we're going to review it again. What does an OSSN look like on OCT? So here's a lesion that could be a little bit subtle. I mean, you see some little hairpin vessels here, and you get a sense this is kind of gelatinous there. So let's look at the OCT. There's the image. And what you see here, again, you first look for normal epithelium, which is dark and thin. Then we see this lesion, which we see as epithelial. So in my mind, I have to decide, is my lesion epithelial or subepithelial? And in this case, this is an epithelial lesion, and there is an abrupt transition from normal to abnormal. Now, here you see the thickness. This measures it for me, is 193 microns. So just remember that for a moment, because our studies have shown that really anything over 120 microns with our OptiView device is very highly sensitive and specific for an OSSN. So even the morphology, which I told you, if you forget, what did she say? Thickened hyperreflective epithelium, abrupt transition. If you forget all that, remember, if your epithelial lesion is, depending on our device, 120, 140, over that, it's extremely likely that it's OSSN. So normal epithelium, I find the base, I decide if my tumor is epithelial or subepithelial. In this case, it's an epithelial lesion of thickened hyperreflective epithelium. This is OSSN, that abrupt transition. So this is what I was mentioning to you about just the thickness. So we looked at this with my custom device and found that if it was over 140 microns, it was very high sensitivity and specificity. And when I used my commercially available device, this was the ArtiView by Optiview, over 120 microns of epithelial thickness, had 100% sensitivity and specificity for OSSN. So we're going to go over again step by step so that when you finish this lecture, you're going to know what to do to diagnose. First, you're going to look for normal epithelium. And remember, that's thin and dark. For the refractive surgeons out there, 50 to 70 microns. So that's what you're going to see first. So step A, find normal epithelium. Next step, find the inferior edge of the epithelium. So here I have that dotted for you. And then you're going to look and see, is the lesion epithelial or subepithelial? And in this case, this is an epithelial lesion. And we see it's hyperreflective, thickened, abrupt transition, and you see that the thickening is 511. So we've decided this is an epithelial lesion. It's thickened and hyperreflective. That's what the lesion is, in this case, an epithelial, and that there's also this abrupt transition. So that has all the features, including the thickness, that it's an OSSN, or ocular surface squamous neoplasia. But let's look at some other lesions in the time that we have. So this is a common problem. Yesterday, I was showing my fellows a similar case of patients referred for this opalescent lesion on the cornea. So let's scan it and see, could this be a corneal CIN or OSSN? So here's my OCT, and this is by the Avanti. So again, first I'm going to look at my epithelium. So my epithelium here is 48, and actually right here, right in the mass of this opacity, my epithelium is 23 microns. And there's this thing underneath the epithelium, not part of the epithelium, under the epithelium. So this lesion is subepithelial. It's between Bowman's layer and the bottom of my epithelium. So this is not OSSN. This is some subepithelial lesion with hyperreflectivity. So this is actually what Salzmann's nodular degeneration looks like. This patient was bothered by it for contact lens use, so I removed it and confirmed Salzmann's nodular degeneration. Another patient, is this OSSN? A gelatinous lesion there temporally? So let's do an OCT. Okay, remember, we're going to find the normal epithelium first. That's 60 microns here. Fine. Follow the epithelium, and it's up here. Is this thick? It's 37. That is not thick. The tumor is below. This is a subepithelial lesion. So you can tell me right now, this is not OSSN. It's jelly-like and maybe referred for OSSN, but it's not. This is a hyperreflective mass, thin epithelium. So we know this is not OSSN. This is what you see with melanoma. And so this lesion was not treated topically. This lesion was removed, and this was conjunctival melanoma. Sometimes we get a pigmented lesion referred for possible melanoma. And here you see this pigmented lesion. But the patient said they thought it had been there a long time, and we look at pictures of them, and they bring in their family albums. And the OCT here shows multiple cysts in subepithelial. There's my epithelium, and there's the cyst. So this is a subepithelial lesion with multiple cysts, and this is classic for a conjunctival nevus. Here's another lesion. We saw one of these yesterday. This is a salmon-colored lesion. This is in the superior bulbar area. And when I do the scans on this lesion, we see thin epithelium. Let's look over here. You see this 50 over here? This is normal looking epithelium, and you follow it. You could say to me, well, here it looks a little hyperreflective. I agree. But you can follow and see that it's thin. And I just want to mention that sometimes the epithelium is a little hyperreflective in pterygia, in patients who have spent a lot of time in the sun, but it's thin when it's not OSSN. So here's thin epithelium. And then what you see is that the problem is below the epithelium. This big thing with dark monomorphic dots, and this hyperreflective band, which I think is compressed tissue. So this is full of cells and it's pushing the normal conjunctiva. See here, the normal conjunctiva is kind of hyperreflective, pushing it. So this infiltrate is a dark, homogeneous infiltrate with little dot-like structures. And this is what you see with conjunctival lymphoma. How do I diagnose that? Well, I need to take a biopsy and send fresh tissue with gene rearrangement to diagnose whether this is a lymphoproliferative disease and if it is lymphoma or benign reactive. What's the treatment? Well, for conjunctival lymphoma, I always biopsy both eyes, regardless of whether I see anything in the other eye, and then the patient gets a systemic workup. So once I diagnose the lymphoma, is it in one eye or both eyes, and is it in the body? If it's isolated to just the eye, the standard gold treatment is external beam radiation. And so that is what this patient had. So there's my diagnosis of that homogeneous hyperreflective. And then after external beam radiation, you see that my salmon patch is gone. And what you see after treatment of my OCT in the same area is the epithelium is normal. And then you see the hyperreflective conjunctiva, but no more dark, black, infiltrative dots. This is a very common lesion that we see, and you see in India too, long-standing lesion. And what this is you see here that there is normal epithelium. Here is some thin but slightly hyperreflective epithelium, and underneath is the stringy white stuff. So this is pterygium. And again, remember I mentioned sometimes over pterygium, the epithelium can be a little hyperreflective, but it's thin. And this is a pterygium. So here's our patient. Remember, we weren't sure what he had. Looked like he had a pterygium for a long time, but something seemed different. And what we see now, so you guys are all pros now, so you can tell me what this is, because you see here some epithelium that looks rather thin, and then you see this thickened hyperreflective epithelium, and then you see this whitish stringy stuff underneath. So what are we worried about this lesion? Because what we see here, again, we're going to see the thin epithelium, hyperreflective, but it's thin. There's the base of the epithelium. This is an epithelial lesion with thickened hyperreflective epithelium and abrupt transition. And then you're going to see there's a little bit of like pterygium-like material, subepithelial hyperreflectivity. So, oh no, this patient has a combination of OSSN and pterygium. So this particular individual had only one eye. He had lost his other eye due to an infection endophthalmitis after cataract surgery. So he was not interested in having surgery on his only eye. So I decided to treat him with topical interferon, which I did, remember, for the 4 months of my usual. And let's see if it's really gone. It looks good. So here I see now when I scan, remember, here you're looking for the normal epithelium. This is the most normal epithelium. And then I see my epithelium very normal here, thin, and an underlying fibrous structure, which is my pterygium. So now I'm happy that I treated this eye and that the tumor is all gone. So let's review one more case. Here's a different lesion. It's focal. It's leukoplakic at the limbus. And this one may not be a big diagnostic dilemma, but I would say it's pretty avascular, but it's very leukoplakic. And so here is the tumor with hyperreflective, thickened epithelium, normal here, and abrupt transition. When it's leukoplakic, you do see more shadowing, although I can actually pretty well see the inferior border. So there's the border, here's my thickened epithelium and my abrupt transition. And then after 4 months of 5FU in this case, you can see how beautiful and normalized. What we said with the excellent questions during the question and answer session is, what do you do if you don't have an OCT? So you treated this patient. I did 4 months of 5FU. That means 1 week cycle. So 1 week every month. Patient comes back in 2 months, looks better. 4 months, looks gorgeous. So I have the luxury of the OCT and I can say, yay, it's all gone. If you don't have it, you could say, you know what, why don't we just be safe and let's just do a little bit more of the 5-FU or the interferon just to be on the safe side. And then what I do is I watch them. So in their first year, they come back every 4 months. And in the second year, it's 6 months. And then after that, it's yearly. Here's the review. OSSN, ocular surface squamous neoplasia. By OCT, what we see is thickened hyperreflective epithelium. You find the normal, you find the base. If it's an epithelial lesion, it's thickened and hyperreflective. Remember the thickness? That's very suggestive. Is going to be something over 120 or 140. This is 260, abrupt transition. This is a classic OSSN. Pterygium. Pterygium is a subepithelial lesion. The epithelium is going to be normal thickness. It can be hyperreflective due to sun damage. And the lesion is subepithelial and hyperreflective. Lymphoma, we see, is subepithelial with lots of little dark dots and homogeneous. And often I'll see this band, sometimes yes, sometimes no, of compressed conjunctiva that's pushed up. And melanoma, I see a normal epithelium and then this subepithelial hyperreflective lesion suggestive of melanoma. And finally is nevus, where we see multiple cysts in the subepithelial area. So in summary then, high-resolution OCT is great technology for ocular surface imaging. There's a very high degree of morphologic correlation with histopathology. And I like to call it my optical biopsy because it provides excellent adjunct to clinical acumen and can help get me the answer.